Hello, my name is Brandon Dickerman. I'm here today to discuss immediate provisionalization utilizing the indirect technique. I'm a third-generation dental laboratory technician from Sharon, Massachusetts, and I have the distinct privilege and honor to work alongside both my father and my grandfather, along with 22 other very talented technicians on a daily basis in our full-service dental laboratory. What I wanted to discuss with you is the Chairside indirect technique. What I mean by that is the ability to work extraorally to do the denture conversion the day of the pro-arch surgery. The advantage to this is it's going to allow the patient to leave the surgical appointment with an immediate provisional, and we're not going to have to work in the mouth in the surgical environment. When we leave the appointment, we were going to have information for the final definitive restoration that's going to allow us to reduce the restorative chair time exponentially. We'll leave with a master cast, which will allow us to begin the final prosthesis fabrication with a leg up and not have to worry about taking records at the first appointment. And at the surgical appointment, the advantage of doing the indirect technique is it's going to allow us to fabricate our provisional while the surgeon is finishing up the surgical appointment, doing their grafting and suturing in the operatory next door. So when we do our indirect technique, we're going to select our abutments and place them in the mouth prior to suturing while the bone is still exposed. And this is going to allow us to get a leg up and begin the process of fabricating the prosthesis while the surgery is taking place to decrease the amount of time that the patient is in the chair. We're going to use the conventional surgical guide that we fabricate, which you'll see in just a moment, to do our intra-oral pickup, and we're going to use the titanium copings and not impression copings to do our pickup and be able to pour our master cast from that. Once we do our pickup, we will place the protective caps on the SRA abutments and allow the surgeon to suture using the protective caps to suture around. And as I said before, we're going to be fabricating the provisional while the surgeon is suturing and doing any sort of grafting that is required. When we show up to these procedures, we want to make sure that we have everything that we're going to need to perform this procedure, because ultimately the patient really is not interested in hearing any excuse that we didn't have the right abutments, that we didn't have any sort of material or consumables that are required to complete the case. So we're going to show up and set up our mobile laboratory in any environment that we have available to us. We can do it in an adjacent operatory, we can do it in the lunchroom, a waiting room. It does not really matter as long as we have electricity. We're going to show up with our kit, which is going to have a lathe, a grinding box to try to contain the mess, and any consumables that we need. The way that we've opted to work is we're going to actually set things up with our kit and actually have an inventory and stock of abutments of all the abutments that we would possibly need with all the different gingival heights and angulations to make sure that we have anything we're going to need chairside. So I want to just talk a little bit about Straumann parts and pieces of what you're going to need chairside. And obviously it begins with having the SRA abutments. So you're going to need to have the straight or 0 degree abutments in the 3 different gingival heights: 1, 2.5, and 4 millimeters. We also want to make sure that we have the 17 degree abutments, which are available in both the A and the B for the CrossFit, giving us 8 different positions for rotation, along with the 2 different gingival heights of 2.5 and 4 millimeters. Same thing with the 30 degree abutment, A and B, and 2 gingival heights as well. During these procedures, what ends up happening is the short driver that you're going to have in your kit is not going to be sufficient in most circumstances. So you want to make sure you have both the long and the extra long SCS driver. The great thing about this system is it continues to use the same driver that is for the entire Straumann line. The occlusal screws that are utilized for the case for the SRA system are very small, and if they happen to fall and hit the floor, chances are you will not find them ever again. So you want to make sure that you have a couple of extra occlusal screws available to you in case this happens. So, not to be used in every circumstance, but to have available to you, you want to make sure you have the plan abutments. The plan abutments are useful in certain circumstances, sometimes are not necessarily that helpful, but you want to make sure you have them available to you. You want to make sure you have enough titanium copings to do the procedure. The indirect technique that we've opted to work up, we need to make sure we have twice as many copings. So if we're doing a case with 5 implants, that normally you'd only need 5 copings, we need to make sure we have 10. So you want to make sure you have enough copings based on the way the conversion is going to be done. The protective caps are very important for us because we're going to, as I said before, put these on the abutments after placing them in the mouth to allow the surgeon to suture around. So just a note on the SCS Driver. If you're working with surgeons who've been using Straumann for quite a while, you'll probably recognize, or they'll recognize, the driver on the left, which is the old style driver. You'll see on the right the new SCS Driver, and you can see the difference is the shank. And this is very important because if we have a very tall coping, or we have acrylic or composite, whatever it is, over the top of that coping, and we have a long chimney to get down to the SRA abutment, the old style driver may be too wide to fit down that chimney and may actually bind and not seat all the way. So you want to make sure that you have the new style driver in both the long and the extra long length. So what I want to do is actually walk through a denture conversion, and I'm going to start with doing the intra-oral pickup. And I want to kind of show this to you through the lens of my camera. I don't want to obviously show this to you using an Elmo cam because I feel this is a little cleaner way to do it. What I need you to do is for the first half of this, just visualize working in the patient's mouth. The recording that I'm going to show you is obviously going to be on the lab bench, but I want you to imagine that you're in the patient's mouth. And in the middle I will allow you to take a quick break, and then you'll be able to see how we move extraorally. So just to start with the components, once again, I'm going to go through the Straumann parts and pieces that we're going to use, but I want to start by just showing you the products and things that we're going to bring to the appointment. And it starts with the conventional surgical guide. This conventional guide is a clear duplicate of the patient's immediate denture that we're going to fabricate, and it's going to have a trough cutout behind the incisal ledge and the occlusal surface of the teeth to allow the surgeon to have guidance of their implant placement. We're going to fabricate an immediate denture, which is going to be full flange, and it's going to have a bite that we're going to fabricate on the lab bench prior to the surgical appointment. And it's really important to come with an immediate denture. In case the implants don't torque, we can have a backup plan. So we're going to use our titanium copings and the occlusal screws, and now we have to visualize being in the patient's mouth, having the abutments already selected and placed, and we're going to seat the copings in the mouth. So when you seat these copings, you've seen a variety of different ways of how people put them in, but the best way to do it is to put the coping in the mouth, use cotton pliers or something to seat the coping on the abutment firmly, and then tighten the occlusal screw. If you try to use the driver with the occlusal screw to seat the coping, it may be very difficult to get it to seat properly. So it may require an extra set of hands, but you really want to seat the coping fully prior to tightening the occlusal screw. Now the abutments are torqued to 35 Newton centimeters, and that's very important because when you put the copings in, they're probably going to be hand tightened, or when we actually deliver the prosthesis, they're going to be torqued to 15 Newton centimeters, and if you don't torque the abutments fully, you may actually back out the abutment when you try to remove the prosthesis, and we don't want to do that. Once the abutments go in, we want to have them in and not removed. So we're just putting on the 4 copings now, and as I said, just try to visualize that we're working in the patient's mouth. Here we are with the 4 copings in place, and now what we need to do is to go ahead and adjust the copings so that they are going to be at the correct vertical position so the patient can close at the proper vertical dimension of occlusion. So what we're going to do is, once again, picture that we're in the patient's mouth. You can see that the coping is actually hitting the opposing arch. And what we want to do is we want to go ahead and seat the guide, make sure it doesn't bind on the acrylic. And we want to make sure that vertically the copings don't need to be adjusted. And what we're actually going to do is mark them. And if you're in the patient's mouth, you can say, okay, we need to take 1 notch, 2 notches off, and we want to go ahead and adjust the height of these copings. And we want to make sure that we do this extra-orally. So we're going to take the coping out, work on the lab bench, and rubber wheel it smooth so it's not sharp. Now you can see that with the copings adjusted, the occlusion is going to be on the guide, not on the copings themselves. So to do the intraoral pickup of these copings, we need to protect the tissue, we need to protect the bone, so we're going to use rubber dam. So we'll seat the copings, and then we'll use rubber dam and place that over the top of the copings to protect the bone and the soft tissue. Then what we want to do is just make sure that the guide is going to seat completely and have the patient close and make sure that there's nothing preventing the guide from seating. Now the material we're going to use is called Triadualine. It's a dual cure composite resin, and it requires a bonding agent to bond to acrylic. So you're going to apply the bonding agent to the guide itself and cure it in the box for a couple of moments. Now what we're going to do is use a light body impression material in the copings themselves to block out the screws in the chimneys to make sure that we're not going to get any of the resin down there, preventing us from being able to remove this from the patient's mouth. And that's what you see us doing here. You want to make sure you fill the entire coping from the screw all the way to the top. So at this point we're going to do our intraoral pickup. Now, as I said before, the material that we use is called Triadualine. It's a dual cure composite resin. We love this material because it's nice and flowable, easy to work with, cures in about 10 minutes in a box, but the initial cure time is about 2 minutes, which is really nice because it allows us to do the pickup. The other thing that's really great about it is, unlike working with acrylic that is going to have a very hot exothermic reaction and generate a lot of heat, this doesn't generate a lot of heat, which could potentially damage the tissues, so it's really nice to work with in the mouth. So when we do this, it's very important to make sure that we syringe all the way around the copings and make sure that we have a nice solid pickup. This is really important because this is going to allow us to generate a master cast, which you'll see momentarily. And if the copings are loose in the pickup, it's going to be very difficult to make sure that we have a very accurate master cast. So in the mouth, you may want to do this 2 copings at a time. What we want to do is syringe around the coping entirely, have the patient close into occlusion, check the vertical dimension, make sure it's still the same and has not changed, and really lock the copings into position. One of the things that we've been doing recently is drilling holes through the buccal surface of the guide, which is allowing us to inject the material in, allowing the patient to maintain a closed position and really get a really nice pickup. So at this point we'll use a light cure gun to cure this material. As I said, you want to have the patient close. It's very important to maintain the vertical position. Depending on the gun that you're using, some of the guns in the market will actually cure this material in a matter of seconds. Some of the older light cure guns on the market, or the less powerful ones, may take a little longer to cure the material. So you want to make sure you have a very thorough cure, so cure everything around, have the patient open, test to make sure the material is really hard, and if you need to add a little more or cure a little longer, you can do so. But you really want to take the extra moment or two to really make sure the material is cured properly. Now, one of the things that we're going to do is fabricate a master cast from this pickup and mount it on the articulator. And the way that we're going to do that is take a bite in the mouth prior to removing the pickup that we did. So you can see what we're doing here, injecting bite registration material on the occlusal surface of the pickup. And then we're going to have the patient close into occlusion to give us a very nice bite. When we do this, we will check to make sure that the vertical is still the same. If there's any discrepancy, we're going to mark that and adjust that when we do our mounting. So now we're going to go ahead and remove the pickup from the patient's mouth. And this is the last time that we will see the patient until we deliver the prosthesis at the end of the appointment. So you just go ahead and clear the access holes of the light body impression material, and then you're going to remove the screws. You want to make sure that you have all 4 screws, and you go ahead and put them aside and keep them clean for the delivery of the prosthesis. Now we'll go ahead and remove the rubber dam, and you can see the pickup. If there's any voids that we're concerned about, we'll just want to make sure we lock the coping into position, make sure it's stable and does not move. At this point, we have reached the end of the intraoral section of our denture conversion. We're now going to move into the operatory next to the surgical suite, or potentially the lunchroom, or wherever the doctor has space available for us to do our conversion. At this point, we're going to be working on the lab bench in a pretty clean environment, which is nice for us as dental technicians because we're not used to working in a bloody field, so it's nice to be able to work in a almost sterile environment to do this. So at this point, we'll take a quick break, and then we will continue. Okay, so the first step in the process of this technique is to pour up a master cast. We're going to do this, which obviously is going to take a little more time than if we were to do the pickup in the mouth and we're going to do the direct technique. But the value that we have with doing this by taking the extra 20 minutes or so is it's going to save on the restorative side of things as far as chair time is concerned on the definitive restoration. In a traditional hybrid workflow, not talking about immediate load, you're looking at about 6 to 7 appointments from start to finish of a hybrid prosthesis. And it starts with getting accurate records, taking preliminary impressions, fabricating bite blocks, doing a tooth setup, then we're going to do a verification jig, framework try-in with the tooth setup on it, and then potentially we'll move towards the processing of the prosthesis. With this technique and taking about an extra 20 to 30 minutes, we're going to have a master cast at the surgical appointment. We're going to have a mounting, and we'll be able to have all the information to start with a verification jig at the first appointment of the definitive restoration. So we're going to actually cut down the definitive restoration from 6 to 7 appointments to 3. And what that's going to do is it's going to allow the restorative doctor to save quite a bit of chair time and make it a little more profitable for him to do this procedure. So what we'll start by doing is we will take the SRA analogs and screw them onto the titanium copings. And now we're going to pour up our master cast. We use a ready base that has mounting pins in it, and we use mounting stone, and what's great about it is it sets rock hard in about 10 minutes. So we really want to spatulate it, make sure it's well mixed. Then we're going to add it to our ready base here, encapsulating the pins really well. And we're going to then go ahead and seat our immediate pickup into our stone. And what we want to make sure of is any surfaces of the acrylic that are going to contact the stone, we Vaseline so that it does not stick. And we'll let this sit for about 10 minutes. And here is the master cast on the right side, finished, removed from the mold. And you can see on the top of the cast there are 3 mounting pins, which is really nice because it allows us to have a mounting that we can separate from the master cast. So at this point, we will go ahead and move towards mounting our master cast in our articulator. So this is a mold release agent, which is going to allow the stone itself not to stick to the mounting that we're about to pour up. And we're going to utilize the bite that we took in the patient's mouth with the lower cast that we already had mounted prior to the surgical appointment. And you can see how it goes together. We'll use some rubber bands to hold the mounting together while we go ahead and mix up our stone and do our mounting itself, which is what you see us doing here. And we're going to make sure that our pin setting, if our vertical was correct, is set to 0. And now we'll go ahead and mix up the stone and do the mounting itself. Once the mounting has set up, probably about another 10 minutes, and that's where the 20 minutes is lost on this appointment, we're going to go ahead and start the process of taking the patient's immediate denture that we fabricated. Now that we know the implants are in and torqued, we're going to go ahead and move towards modifying that and turning it into an immediate load prosthesis and a hybrid restoration. So the way that we do this is we come to the surgical appointment with an OmniVac shell that was done over the top of the denture. And we're going to use this to mark the top of our copings. So we place the shell on top, mark it with a Sharpie. So now we've registered the top of the coping positions. And we'll use this to simply place this on the denture and just mark where the holes, the access holes for the titanium copings are going to come through. The goal here is to minimize the damage that we do to the denture and minimize the size of the holes that we have to put through it, because that's going to make the prosthesis weak and potentially fatigue quickly. So we want to make sure this is going to last for 3 to 4 months or however long it's going to be before we fabricate the final restoration. So we want to minimize the fatigue that we put on this prosthesis. So you can see all we're doing is just putting a dimple and marking the top. We're not drilling through as of yet. Now when we remove this, you can see the dimples that we've put in the top of the denture. So at this point we need to register where the SRA abutments are coming through the tissue. So what we're going to do is utilize some bite registration material. We will inject it onto the intaglio surface of the denture, and we're going to seat this on the master cast and close the master cast on the articulator so the vertical is correct. And this is going to register the abutment locations. So you can see all we're doing here, injecting some fast set bite registration material, seating it on the master cast, and closing it into occlusion. Now once this has set up, we will remove it from the master cast, and we'll have a very nice representation of the abutment locations. And now once again we're just going to put a dimple on the denture base and mark where the abutments are showing and where the copings are going to be going through the denture. And when we peel this out, we'll have a nice representation. At this point we'll actually drill the access holes. So now we know where the top position is, we know where the intaglio position is. We want to try to line up our round burr to be able to punch through right where the long axis is going to be. So we'll just kind of look from the bottom and kind of get a feel for where the position is. We'll just go around and mark the positions and drill through. We'll do this for all 4 of them. Now we're not making massive holes yet, we're just creating little round burr holes. The number 8 round burr is what we're using here, just so we can seat this on the master cast and see how we line up with the abutments. And then we can obviously open up the holes for the copings. So you can see how it falls and lines up, and then one by one we'll be able to open this up, seat one coping at a time, and get everything to line up perfectly. So one of the things that most likely we're going to have to do, especially if we had to do it in the mouth, is adjust the length of the titanium coping. So we'll just shorten it a little bit. We usually use a disc, and then we'll use a rubber wheel to just smooth it off. And each time we do this, we're going to open this up and make sure that the denture seats completely. And so we'll just open it up little by little, make sure it seats. If it doesn't, we'll go ahead and open it up a little more. And we're going to do this until all 4 seat passively in the denture base. And as I said, we want to do it little by little because we want to create reasonably small holes that are not going to fatigue the prosthesis. So one of the things that we're going to do here, which is something that we're utilizing now in the mouth to do our pickup, is we're going to prepare the denture base by creating little access holes through the buccal surface so that we have an injection point for injecting our pickup material. So we'll just go around for the 4 copings and drill a hole in each of them. That's what you see us doing here. And once we do that, we'll also go ahead and do it on the palatal aspect. So we have 2 injection points, so we can really make sure we have a nice pickup without any voids. But chances are, even by doing this, we'll still end up with voids that we'll have to backfill later. So just like with the pickup, we're going to use our triad dual line, which requires a bonding agent. We're going to apply this. It bench sets for about a minute, and then it cures in a light cure box for 2 minutes. And it's going to break down the acrylic a little bit with the bench set, and then have a surface that the material will bond to. And we've done about 35 arches in the last year or so, and we haven't had any sort of delamination of this material to the denture base. They are not both similar materials, they're dissimilar, but with this bonding agent, it does create a pretty strong bond, and if you do this and take care at this step, you can have a immediate load prosthesis that should not fracture on you. So just like in the mouth, we're going to work with rubber dam on the cast just to protect it, keep everything clean, and not lock it on to the stone of the cast. So we'll put our rubber dam on, we'll seat our denture, and once again we're just going to check that it seats properly, and we will use our triad dual line to do our pickup. We'll inject it from all of our access points that we've created, both in the buccal and the palatal. You can see that it oozes through from the opposite side, which is what we're looking for, so any air escapes. And then we're going to cure it with our light cure gun. So the initial bench set of this with the light cure gun is a couple of minutes, but then definitive set time is going to be done in the cure box for 10 minutes. And we're using plastic Q-tips just to make our access channels stay clear, extend the length of them over the top of the copings. So one of the things that we utilize are protection caps. We've opted to make our own utilizing the SRA analogs that we've just cut off. There are SRA protection caps available or polishing aids available that is in the Straumann catalog, but it depends on what you want to use. It doesn't really matter. But the idea here is we're just going to go ahead and protect the interface from any sort of grinding. It's really important that the seat of the coping on the abutment is preserved. So we're going ahead and backfilling any voids that we have. Chances are you're always going to end up with some, and we just want to make sure we have a nice pickup done here. And once the voids are filled, we'll put it in our curing box for 10 minutes for the final set of the material. Now at this point we're going to go ahead and finish down the prosthesis. So we're going to remove our flanges, and we're going to remove the palate and start to contour this to ideal contours. So here we are. We're using a big knockdown wheel or a big fiber disc to just remove the masses of material that we don't want here. You can see us removing the palate. And then we'll start going ahead and creating more ideal contours of what a hybrid restoration would look like. We want to remove any concavities if possible. We don't want to create a food trap. We want to have ideal contours. We want to have nice intimate contact with the tissue. And we're just going to finish this down, and you can see how the occlusion lines up. And the goal here is not to have any sort of cantilever on the immediate load prosthesis. With the final restoration with a Chairs titanium framework, we can have a cantilever, but for an immediate load prosthesis that is not supported, we want to remove any sort of tipping forces on these implants, because that will A, weaken the implant, and B, it is going to be tough on the prosthesis, which is only held in by those titanium copings that are not splinted together. They're only splinted together by the pickup material, not a rigid titanium framework. So you can see these are the contours that we have here, that we have created, and now we're going to just smooth everything off and polish it down. And we want to try to remove any rough surfaces that are going to be problematic for buildup of plaque and bacteria. So we'll finish it down using pumice, and we really want to get a nice high shine of this prosthesis. So we want to work all the different contours, the intaglio surface of the prosthesis. We've removed all the flanges, so we want to make sure it's nice and smooth, and that's what you see us doing here. And on the right, the final immediate load prosthesis with the protection cap still in place. So now we'll remove the protection caps, we'll screw it back onto our master cast, and we will just check to make sure that our occlusion is still spot on. If we want to do any sort of occlusal adjustments on the cast, we can. We can wait to do that in the mouth as well. So I just want to thank you for spending a little bit of time with me and looking through the lens of my camera at how we do these immediate load conversions chairside the day of surgery. If you have any questions, please feel free to contact me, 781-828-2808, or feel free to email me anytime at brandon@dickermandental.com. Thank you very much, and have a great day.